Thank you for joining us today for Orgasm Cervical Artery Dissection with Daniella, Kadian-Dodov. Dr. Kadian-Dodov is an assistant professor of medicine at Icahn School of Medicine at Mount Sinai. She received her medical degree from Oregon Health and Science University in Portland, Oregon, after which she completed her internal medicine residency here at Mount Sinai. She stayed on to complete her vascular fellowship at Mount Sinai as well. Dr. Kadian-Dodov has publications in basic science research regarding the behavior of vascular endothelial cells and clinical research investigating the diagnostic role of vascular ultrasound and the clinical experience for patients with fibromuscular dysplasia. She has a dedicated vein practice for patients with post-thrombotic syndrome, varicose veins, and venous insufficiency. She currently is involved in several research trials focusing on improving knowledge in pathophysiology, genetics, and management of the fibromuscular dysplasia, as well as serving as a clinical investigator for large-scale trials of peripheral artery disease throughout Icahn School of Medicine at Mount Sinai. Please join me in welcoming Dr. Kadian-Dodov.
Thank you so much. It's an honor to be here with you all today. I'm going to be discussing cervical artery dissection, new insights, and continued controversies. I have no disclosures. I will go over off-label use of the new direct oral anticoagulants in the treatment of cervical artery dissection over the course of this talk. And my agenda is fourfold. So I'm going to address the predisposing factors and presentation of cervical artery dissection. I'll go through the new understandings, including genetics of the disease and other disease associations. I'll be discussing the treatment debate, specifically antiplatelet therapy versus anticoagulation and where the direct oral anticoagulants might fit into this. And then patient prognosis and follow-up long-term. So to start the discussion, I'm going to begin with a case. This is a patient I saw about 1.5 years ago. It was a 28-year-old gentleman who presented with new left-sided neck pain radiating to the top of his head. 1 day later, he experienced right-sided neck pain. He had tried some over-the-counter analgesia without any improvement in his symptoms. He had no known injury, but the week prior had moved and was doing some heavy lifting. And at baseline, he noted that he would often manually crack his neck by pulling it over to one side because of perceived neck stiffness. He has a past medical history of ADHD, and his family history was notable for subarachnoid hemorrhage in multiple family members on his father's side. So his father experienced a subarachnoid hemorrhage at age 53 and actually died as a result of that. His paternal aunt had a subarachnoid hemorrhage at age 58 and died as a result, and his paternal uncle experienced a stroke at age 55, was alive, but further details were really not known regarding this. Otherwise, there was no family history of cardiovascular disease, aneurysm, dissection, or sudden death. He was not a tobacco user. He did engage in marijuana daily, no other illicits, and he was an electrical engineer. So because this had been going on for a while, his primary care provider referred him to Neurology, who ended up ordering a CTA of the head and the neck. So the arrow was pointing out the left vertebral artery for you. We'll keep an eye on that for now. And what you'll notice is that it begins to taper down quite a bit, and then farther up, it returns to normal caliber. Now switching over to the other side, the right vertebral artery will come into view. There's what is a double lumen. You can see there's like a flap in between with 2 channels of flow, which continues as you go up the neck. So these imaging findings are consistent with cervical artery dissection, which is an intimal tear or rupture of the vasovasorum that allows blood flow to separate the wall layers in the carotid and vertebral arteries. It accounts for up to 1/4 of strokes in patients age 45 or younger. And historically, it was really only identified on autopsy until the modern imaging techniques came into being, which really began with this gentleman, Dr. Igaz Moniz, who was the first chairman of neurology at the University of Lisbon in Portugal. He actually also had a political career and served as the ambassador to Spain for Portugal in 1917. But he's credited with 2 main accomplishments in medicine. First, he discovered cerebral angiography in 1927 and originally observed an internal carotid artery occlusion. And second, he actually won the Nobel Prize in Medicine in 1945 for the introduction of lobotomy to treat mental illness. So he made a few notable observations regarding his findings on angiography, and he really stressed the role of angiography for the diagnosis of an internal carotid artery occlusion. So he said thromboses of the internal carotid and its cervical course are of great interest, for before the days of angiography, this diagnosis was not made, its existence was not even thought of. Second, he observed a wide variation in the presenting signs and symptoms with this. In one, he noted there's hemiplegia due to internal carotid artery thrombosis in not very old subjects. However extraordinary it may seem, there are also complete thrombosis without any symptoms at all. So internal carotid artery dissection is more common than vertebral artery dissection. The rate is thought to be up to 3 per 100,000 person years for internal carotid arteries. It most often affects the cervical segment beginning about 2 centimeters beyond the bifurcation, extending up to the entry point into the skull. The vertebral artery also most commonly occurs in the extracranial segments, with the incidence rate reported of 1 to 1.5 per 100,000 person years. And the way that these patients present classically is a younger patient with a paucity of typical atherosclerotic risk factors. They may experience unilateral head or neck pain. Neck pain is more frequently observed in patients with vertebral artery dissection, while headaches are more often reported in patients with carotid artery dissection. The pain is usually ipsilateral to the affected side and may radiate up to the head or the side of the face. Stroke is reported in up to 70% of patients in the literature, although most of the literature is surrounded around stroke centers, so it may be overreported. And TIA is also seen in about 25%. Stroke is more common in vertebral artery dissection, but those patients with stroke and internal carotid artery dissection actually have more severe manifestations. Horner syndrome is a common size, which is meiosis and ptosis, shown in the image here. Amaurosis fugax was transient monocular blindness, a shade coming down over one eye, and vertebrobasilar symptoms in the case of vertebral artery dissection. Pulsatile tinnitus is reported in up to 27% of patients. So cervical artery dissection really is an imaging diagnosis. Historically, it has been identified with catheter-based angiography, but this has really been replaced in more modern times with MR and CT angiography, which have near 100% specificity and sensitivity for detection of this. MR angiography shows you superior resolution of the intramural hematoma, particularly with the T1 fat suppression images, and can also assess for cerebral ischemia when paired with MRI. CT angiography is more rapid, as we know, and may offer superior resolution of the intimal flap. And these are some examples of the pathognomonic findings of cervical artery dissection. So on angiography on the left here, you see the carotid bifurcation and then a flame-tipped occlusion of the internal carotid artery. As compared to on this side, a long, smooth tapering with return to normal caliber farther on, much like the gentleman I presented. Other findings include visualization of the intimal flap, which you can see in the left vertebral artery here, as well as a double lumen on cross-sectional views. And with time, patients may have aneurysmal degeneration of the artery as it recanalizes following dissection, or other complications like a pseudoaneurysm or dissecting aneurysm. Duplex ultrasound actually is a good technique as well for visualization. It has over 90% accuracy in making the diagnosis. It can image the double lumen, which you're seeing here. So this is the internal carotid artery, very distal, almost at the entry point to the base of the skull. And you're observing 2 lumens of flow here with an intimal flap. The right vertebral artery on this side coursing through the vertebral bodies. And again, 2 lumens, 2 channels of flow. And this is an excellent modality for serial imaging to monitor and follow patients long-term when they get out of the window of need for repeat CTA and MRA. So most of the contemporary data on cervical artery dissection comes from this CADISP group, which is the cervical artery dissection in ischemic stroke patients. This is a European consortium with Argentina included, of 20 centers over 9 different countries, which are shown in the map on the right there for you. The primary aim of this consortium was to identify genetic polymorphisms that might be associated with increased risk for cervical artery dissection. They used both prospective and retrospective recruitment to get the number of patients listed below. So they were targeting 1,100 patients with cervical artery dissection, 1,100 with ischemic stroke not due to cervical artery dissection, and then healthy controls, 2,000 patients who had no history of vascular disease, and they were matched by geographic origin. All patients underwent a stroke neurology evaluation to assess for criteria for entry into the consortium. They were all over or equal to the age of 18. Dissection patients had to have a dissection that was defined by imaging characteristics, and those were the characteristics that I showed you before. And they excluded patients with possible other underlying causes for the dissection, such as iatrogenic causes or heritable connective tissue diseases, and I have some examples of that on the next slide. The ischemic stroke patients were age and sex matched within a 5-year age range. They had no evidence of dissection on imaging, and they were excluded if it was a possible ischemic stroke they weren't able to definitively determine, or if it was an ischemic stroke due to other cause, such as autoimmune disease or thrombophilia, and if they had had a recent procedure within 48 hours. And then the healthy patients, as I mentioned, had no history of vascular disease. So these are some heritable connective tissue diseases that are associated with cervical artery dissection. Loeys-Dietz syndrome on the top, which is defined by the triad of extreme arterial tortuosity, which you can see here with the cervical and vertebral arteries making many twists and turns, a bifid uvula, and hypertelorism. There have been 4 different genes that are now associated with Loeys-Dietz, and there's a spectrum of severity of manifestations for these patients. And then on the bottom here, Ehlers-Danlos type 4 vascular type, which is due to a mutation in the COL3A1 gene. These patients experience arterial dissection, aneurysm, and rupture, as well as intestinal and uterine rupture. And these are some of the features on exam that you may see for the patients. Hypertelorism again, thin bridge nosed, thin upper lip, acrogaria, which is a aging appearance to the patient, and then thin skin with visible veins. So these patients were excluded from CADISP. So what they did was they had each patient fill out a clinical questionnaire that included family and past medical history, clinical signs and symptoms, imaging results. A connective tissue exam was performed on all patients, and then information on therapy and 3-month outcome was obtained. They also obtained DNA samples from the patients for GWAS analysis and evaluation of candidate genes that could be involved, including those genes that are associated with the connective tissue diseases that I just mentioned. So the main lessons to come out of this were that overall, cervical artery dissection was slightly more common in men, but women in general presented about 5 years younger. So if you look at the graph on the right there, you can see that the peak for women is at about 5 years younger. And other than hypertension, it really wasn't associated with the traditional cardiovascular risk factors. Interestingly, an underlying arterial abnormality may predispose to some environmental risk for these patients, and I'm going to go through some data on histopathology to support that, as well as an association with other arteriopathies and migraine, and perhaps even a genetic susceptibility. So vessel redundancy has also been reported in patients with cervical artery dissection. This was a retrospective study that looked at 13 patients with dissection compared to over 100 age and sex-matched controls with cervical neck imaging. And what they found was that the dissection patients had a higher rate of vessel redundancy, including this extreme tortuosity, or S-curve as we call it in the vascular lab, loops, kinks, coils, much higher rate as compared to age and sex-matched controls. Additionally, pathologic changes have been reported on superficial temporal artery biopsy. So this study looked at 14 patients with spontaneous cervical artery dissection versus 9 accident victims with pathology specimens from autopsy as age and sex-matched controls. And the spontaneous cervical artery dissection patients underwent superficial temporal artery biopsy, and they observed several pathologic changes for the temporal artery. So above here is normal, and the bottom slides are the patients with cervical artery dissection. Some of the things that they saw were microhematomas occurring in between the media and the adventitia, as well as defective neoangiogenic capillaries in the patients with dissection. They also saw erythrocyte extravasation on high power between the media and the adventitial layers. So what about the patients that have more than one cervical artery dissection? Can we learn anything from them? In the CADISS study, out of 983 cervical artery dissection patients, just over 15% had multiple cervical artery dissections. And what they found was that those patients were 4 times more likely to have fibromuscular dysplasia as identified on CTA and MRA. There were higher rates of hypertension and tobacco use reported in those patients. They more often presented with cervical pain and more often had pseudoaneurysms identified on imaging. Happily, it was not associated with a higher rate of TIA or stroke, despite having multiple arteries dissect, and there was no difference in functional outcomes in the long term. Interestingly, they also looked at cervical artery dissection in physicians in CADISP, and they decided to go down this pathway after 2 of their colleagues ended up suffering a cervical artery dissection over the course of the study. There was a higher rate of physicians in the cervical artery dissection versus the ischemic stroke group. And there was also a higher rate of FMD and intracranial aneurysms in the physicians with cervical artery dissection versus the cervical artery dissection patients that were not physicians. So what is fibromuscular dysplasia, since I've mentioned it a few times now? So this is a non-atherosclerotic, non-inflammatory arteriopathy that most often affects the carotid and the renal arteries. And we've learned recently that there's really a manifestation, a wide range of manifestation to the diseases. So there's the characteristic string of beads that we all learned about in medical school, shown here. Patients can also experience a focal area of stenosis in the mid to distal artery, shown here, dissection, aneurysm, and arterial tortuosity. At this point, we only attribute dissection, aneurysm, and tortuosity to FMD if we see the typical multifocal or focal findings in another artery bed. And that's because a healing dissection can actually mimic the multifocal string of beads FMD type as it's on imaging. The demographics and presentation of this disease are as follows. So 94% of patients are women. There's a mean age of diagnosis around 54 years. However, there's also a mean delay to diagnosis from symptom onset of about 4 to 9 years. The manifestations depend on the artery that's affected. In the case of the carotid and the vertebral arteries, headaches, neck pain, pulsatile tinnitus, TIA, and stroke in patients that have dissection related to FMD, renal arteries, hypertension, iliac arteries, claudication, and in the coronaries, myocardial infarction and chest pain also associated with dissection in that arterial bed. And aneurysm and dissection is actually very common in this group of patients. So this is data from the US Registry for FMD. It includes 921 patients at the time of FMD diagnosis. And what was observed is that roughly 41.7% of patients experienced an aneurysm and/or dissection at the time of FMD diagnosis. And the most common locations of these events were for dissection specifically, the extracranial carotid artery 64%, vertebral artery 21%, followed by the renal artery. And when you look at the whole group lumped together, 19% of patients experienced a cervical dissection overall. So perhaps these could be the same disease on a spectrum, because the only way that we're really distinguishing dissection related to FMD versus spontaneous cervical artery dissection is when we observe those typical multifocal or focal FMD findings in another arterial bed. But if you look at the demographics and the presentation of these two processes with those definitions, there's a lot of overlap. So the mean age of diagnosis, 44 years for cervical artery dissection as compared to, in the case of FMD dissection, about 48. Gender, men slightly more common than men for cervical artery dissection, but women present younger. Women more often with men, but men with FMD are more likely to have dissection or aneurysm. In terms of risk factors, both groups have a paucity of atherosclerotic risk factors. Migraines are frequently reported in both groups, more than 50% in patients with FMD. Hypertension is common. And in terms of symptoms at presentation, cervical artery dissection patients, as we went over, present with pain syndromes, pulsatile tinnitus, stroke, and TI, whereas with FMD, they may have end-organ ischemia if they're experiencing a dissection. About 30% of patients report pulsatile tinnitus. And again, cervical artery dissection is quite common in the US registry patients. Now, genetic susceptibility has also been looked at. So there's a polymorphism for this factor 1 gene that's been associated with a susceptibility for cervical artery dissection. And actually, the same polymorphism was recently identified in FMD patients. So this was reported at the American Heart Association last year, and the manuscript is actually in press now with PLOS Genetics. And this factor 1 gene is a protein that's encoded on chromosome 6. It's a member of the phosphatase and actin regulator family of proteins, and it plays a role in tubule formation and endothelial survival. The top variant of this protein and gene is associated with an increased risk of myocardial infarction and coronary artery disease, and then a decreased risk of cervical artery dissection, FMD, and migraine. And migraine has long been associated with cervical artery dissection. Many postulate that it's the link between migraine and stroke in the young. In fact, migraineurs have about 2 times the risk of a cervical artery dissection that's independent of gender and presence of aura. CADISP confirmed that there were high rates of migraine in patients with dissection as compared to ischemic stroke, mostly due to migraine without aura. Migraine and cervical artery dissection is more common in women, although there's no difference in the stroke rate, number of dissections, imaging findings, overall prognosis, or complications for these patients. So switching over a little bit now to the environmental risk factors, I wanted to review minor cervical trauma, which can include things like cervical spine manipulation with chiropractors, extreme head movements, over twisting or bending, heavy lifting, whiplash, and then sports-associated injuries. So this is information from an observational study of nearly 2,000 participants from CADISP who completed a standardized clinical questionnaire and reported these minor cervical trauma within 1 month prior to presentation of their event. There was no difference in the mean age between patients with cervical artery dissection, ischemic stroke, or controls, or sex distribution between the groups. There was a higher rate of migraine reported in the patients with cervical artery dissection. And what they found is that overall, there is a higher rate of minor trauma in patients with cervical artery dissection as compared to ischemic stroke, with an odds ratio of 6.5, as well as cervical artery dissection as compared to controls. And this was a finding that held true across all subtypes of minor cervical trauma, from cervical spine manipulation, whiplash, et cetera, down the list. And in looking at patients with cervical artery dissection with or without minor cervical trauma, there were a few notable observations. So these patients more often presented with neck pain. There was no difference in the artery dissected or presence of multiple artery dissections for patients that had a minor cervical trauma. They less often experienced stroke, and when they did, their stroke was less severe, and it was not associated with any difference in outcomes out to 3 months. But definitely a risk factor for cervical artery dissection and should be probed for when considering the diagnosis in these patients. So in putting it all together, the etiology and predisposing factors, I think there's really an overlap of arterial wall weakness underlying, which may be due to an arteriopathy like FMD. Heritable connective tissue diseases should be considered, and then structural arterial abnormalities that have been observed in these patients, as well as arterial wall stress, such as trauma, hypertension, migraine headaches. For patients that have a cervical artery dissection, two things that are not in the differential for them is a vasculitis or a thrombophilia. So there's one case report in the literature of a cervical artery dissection that occurred in a patient with Takayasu's arteritis, but other than that, there's no reported association for spontaneous cervical artery dissection. So coming back to our case of the 28-year-old gentleman with ADHD who had the significant family history of subarachnoid hemorrhage in multiple family members, now presenting with bilateral vertebral artery dissections on CTA. What do we think the etiology of this dissection is, and how would you treat him? So regarding the question of the underlying arteriopathy, I was quite concerned about his family history. So we obtained a CTA, chest, abdomen, pelvis. We didn't identify any FMD anywhere. There were no renal cysts observed. I did send him on to CVI genetics for an evaluation for underlying monogenic disorder. He had no systemic signs of a heritable connective tissue disease, and they did do full genetic testing for vascular Ehlers-Danlos syndrome, Loeys-Dietz, thoracic aortic aneurysm and dissection, and other polymorphisms that have been associated with aneurysm and dissection, all of which came back negative. So we gave him the diagnosis of a spontaneous cervical artery dissection. With regards to treatment, there's some things to consider. So the majority of strokes occur within 7 days of symptom onset for these patients, and the symptoms can be pain, and then more specifically TIA is of great concern. After that 7-day period, the stroke rates are very low, and there's a couple of different ways that patients can have ischemic events with dissection. So the first is that intimal flap and tear, thrombus formation at the site of injury, and then embolization downstream. Much like what you think about for stroke related to atrial fibrillation. Now, the other possibility is thrombus propagation and complete occlusion of the artery, and that's when you get that flame-tipped occlusion that we see on imaging. And when that occurs, about 30% of the time, patients may experience a stroke. So which one is it? They actually did some investigations, and this was the largest study that I could find. It was a retrospective evaluation of 100 consecutive patients with acute stroke on MRI and no prior history of stroke. All patients underwent MRI with the infarct territory noted, specifically cortical, subcortical, or watershed. All patients underwent carotid Doppler and transcranial Doppler, and they had their velocities evaluated, low velocities indicating low flow, high velocities indicating a critical stenosis, high intensity transient signals on transcranial Doppler, which are markers of microemboli. And what they found was the vast majority of these patients had findings that were consistent with thromboembolic events. Far less had those consistent with hemodynamic compromise, and even fewer had a mixed mechanism. Now, there's been a lot of debate over anticoagulation versus antiplatelet therapy for the treatment of disease in these patients. And the American College of Cardiology and American Heart Association in 2011 came out in favor of anticoagulation over antiplatelet therapy in the acute setting because of the proposed mechanism of stroke for these patients, and also based on data from the Canadian Stroke Consortium, which included prospective data from 116 patients. So what they found was that the event rate per year was lowest in those patients receiving anticoagulation versus aspirin or other therapies, which was other antiplatelet therapies. And actually the American Heart Association and American Stroke Association in 2014 came out with a further update that said, based on the data available, either anticoagulation or antiplatelet therapy is acceptable, making things even more confusing. Now, the American College of Chest Physicians recommends aspirin over antithrombotic therapy for the treatment of acute stroke of any subtype based on the lack of evidence to support antithrombotic therapy over antiplatelet therapy. And what you see in the graph or the table listed below there is a 2015 meta-analysis, which includes about 1,400 patients over the years of 1979 to 2012. And all of these were observational studies. And for all of the endpoints that they looked at, death all causes, death and disability, ischemic stroke, symptomatic intracranial hemorrhage, or other major bleeding, there was really no difference observed between the two groups. The only study with randomized data available is this one, which was published in 2015. It was the cervical artery dissection and ischemic stroke study, a phase 2 feasibility study across 39 centers in the UK and 1 Australian stroke center. It was open label for the patients and the investigators, although the adjudicators were blinded to allocation. And patients were assigned to either antiplatelet therapy or anticoagulation. The inclusion criteria included symptoms for less than or equal to 1 week, and then imaging with definite or probable cervical artery dissection. And they actually included carotid Doppler in that, as long as it was followed up with further imaging after randomization. So I want to draw your attention to this box here, because 53 patients did not actually meet inclusion criteria after they had been randomized. And actually, when they went through central imaging review to confirm the diagnosis of cervical artery dissection, they weren't able to do so for 20% of patients that were enrolled. So in the per protocol analysis, we were left with nearly 200 patients. In terms of procedures and follow-up, the agent, whether it was antiplatelet or anticoagulation, was up to the investigator's discretion. No novel agents were used, no novel anticoagulants. And the antiplatelet subgroup was allowed to receive prophylactic heparin for prevention of venous thromboembolism while they were on treatment. And they underwent 3-month follow-up for outcomes, which included CTA when they were able to get one. The primary outcome that they looked at was ipsilateral stroke or death from any cause within 3 months of randomization. And then they had a variety of secondary outcomes, which were composites of TIA stroke, death, any cause, even residual stenosis on follow-up imaging and major bleeding. And what they found was that there was really no difference between the groups in terms of presentation. There was quite a high rate of ischemic stroke, 70 to 80% reported. And the time between symptoms and randomization was roughly around 3.6 days across all groups. They found no difference in ipsilateral stroke or death for either the intention to treat or per protocol analysis. There was 1 major bleed in the anticoagulation group and no difference in any of the other secondary endpoints. So based on this, the authors concluded that there was no difference in therapy, and therefore antiplatelet therapy should really probably be used up front. But did it really answer the question? And I'm going to say no for a variety of reasons. Number one, many patients enrolled didn't have a confirmed cervical artery dissection on imaging review. They didn't use pre-specified criteria to make the diagnosis prior to enrollment. The mean time from symptom onset to randomization was 3.6 days, and as we went over before, within that 7-day period is the highest risk for an ischemic event. We had no information on what treatment patients received prior to randomization. And I think there's a question of whether or not the patients actually met the primary endpoint prior to recruitment. So they did do a post hoc analysis of the patients that had stroke at diagnosis or at enrollment, and they identified that about 20% of these patients reported prior symptoms somewhere in the time range of 1 day to 21 days. So I'm not sure that these patients didn't meet the primary endpoint before they were recruited. The time within the therapeutic range was not reported for the patients that were receiving warfarin. And in general, the study was really underpowered to draw any conclusions. The authors ended up estimating that the number needed to recruit in order to answer this question would be about 10,000 subjects. And that would be to just detect a 1% difference between the antiplatelet and the anticoagulation group. I think one important takeaway, though, is after that initial ischemic event in the longer term, the stroke rates are quite low. We only saw about 1-2% in this group, which is consistent with prior studies. And what about the novel agents? So this is extrapolating data from non-valvular AFib, where the novel agents have equal efficacy in stroke prevention with favorable safety profiles, which makes them attractive for the treatment of cervical artery dissection because these are predominantly younger patients with lower bleeding risk anyway. And this was one study, which was a single center retrospective review of about 150 patients that were discharged on a variety of antiplatelet novel agents or traditional anticoagulation treatment. One thing that was noted was that those patients with severe stenosis or occlusion more often received anticoagulation, whether it be a novel agent or warfarin therapy. And what they found is that at follow-up of about 4 to 5 months, there was no difference in the recurrent stroke rate. There was some imaging progression. So for those patients that had an occlusion initially and they were receiving the novel agents, there seemed to be a longer segment occlusion at follow-up, which is interesting. And the major bleeding was highest with traditional anticoagulation. So putting it all together, what do? Our treatment for acute dissection is anticoagulation for 3 to 6 months over antiplatelet therapy generally. And we prefer that based on the proposed mechanism of stroke in the patients, and also because I think as we're seeing patients in the outpatient arena, we often are picking up those patients that may present just with pain syndromes and not necessarily TIA or stroke already, so they may be within that window of real benefit for receiving treatment. If they're going to be receiving antiplatelet therapy, I think aspirin 325 daily is preferred. There's few data in the literature for dual antiplatelet therapy with aspirin, clopidogrel, or other agents in those small studies that have been done over the past 30 years now. We've had good experience with the novel agents, so we consider them an acceptable alternative to heparin and warfarin if the patient prefers it, and also if there's a poor response to heparin or warfarin, such as labile INRs. For those dissections that are incidentally identified on imaging, we put those patients on a daily baby aspirin indefinitely. In terms of the advanced therapies, thrombolysis is actually not contraindicated in the acute phase of treatment. In the CADISP subgroup, the patients that ended up receiving thrombolysis had no difference in outcomes, and it was not associated with higher bleeding. There's no data to suggest that they're doing any better by receiving thrombolysis, but they're not receiving harm, at least with the literature that we have. Endovascular and surgical revascularization really should be reserved for complicated cases, which is continued symptoms of ischemia despite treatment, and then high-risk imaging features like pseudoaneurysms that are complicated. But in general, the vast majority of patients do really well with medical therapy and conservative management. So when at all possible, I think this should be the treatment goal, which is anticoagulation followed by a transition to long-term baby aspirin daily. So what ended up happening with our patient with the bilateral vertebral artery dissections and no ischemic symptoms? He was discharged from his hospital on warfarin. He ended up seeing me in the clinic initially, and since discharge had had labile INRs. In addition, he was reporting a needle phobia and had a lot of anxiety regarding his INR monitoring. So we ended up transitioning him to rivaroxaban 20 milligrams daily. And then he had a lot of questions regarding what his expected prognosis is and what other precautions he should take in the long term. So in terms of prognosis, as I've said already, the majority of patients really do well. The one main predictor of long-term outcome is the NIH stroke score for stroke severity at patient presentation, which ranges from 1 to 42. And just to give you an idea, the mean NIH stroke score in CADISP was about 5.95, which is in the mild to moderate range for the NIH stroke score scale. In terms of follow-up at 3 months, the modified Rankin score is often used, and for over 80% of patients at 3 months, they had no symptoms to a slight disability, whereas 63% of patients had no symptoms to symptoms with no objective disability. So again, in general, they do quite well in the longer term. In terms of imaging prognosis, about 50% of dissections demonstrate complete recanalization on follow-up imaging. The remainder have stability, and specifically pseudoaneurysms. They don't seem to degenerate further. That's quite rare when it does happen. What about the risk for a recurrent dissection, which is a big question that patients have? Well, it's also quite low. This is data from the Mayo Clinic with follow-up out to 10 years. And the highest risk for recurrence is within that acute period of 2 to 4 weeks, at which it's about 2%. Thereafter, the rates are stable at 1% per year. So in terms of treating and following up these patients in the longer term, in the acute phase, following a dissection, we anticoagulate, we target blood pressure and pain control, and we obtain imaging after the event at the 1 to 3 month range, and then again at 6 months with CTA or MRA. At 6 to 12 months, we use the patient's symptoms, mainly pain, which can persist after a dissection for months, sometimes even out to years, as well as imaging changes to help us guide therapy. So if there's improvement or resolution, at that point we might change their anticoagulation to a baby aspirin a day. If there's no improvement, we might consider carrying out the anticoagulation to 6 months and re-imaging at that point. Again, blood pressure and pain control is a target for us. And then finally, we get imaging at 12 months. Thereafter, in the longer term, patients are generally on a baby aspirin a day indefinitely, and then further imaging is really customized to the patient's findings. In terms of additional precautions, for blood pressure control in the long term, ideally we like to see patients below the 130/80 range if they can tolerate it. If they don't have hypertension before a cervical artery dissection and they don't have hypertension afterwards, I would say less than 140/90. We advise that they avoid heavy lifting and intense isometric exercise. I also advise patients to avoid high G-force activities like roller coasters that can predispose them to whiplash. Chiropractic neck manipulations, deep tissue massage of the neck area. For those patients that are in yoga, I also advise against headstands. And then there's really just a gradual reintroduction of cardio activities. So at about 1 month, they can start light walking, 3 to 6 months, more intense cardio, perhaps keeping that maximal heart rate under 75%. So for our 28-year-old with spontaneous vertebral artery dissections who transitioned from warfarin to rivaroxaban, at 3 months he had stable imaging findings and continued neck pain about twice a week that he described as moderate. He was using about 1 Percocet a month to control his symptoms. So we continued him on anticoagulation for an additional 3 months. We ended up adding propranolol to his regimen to just see if we could get some control over his pain. He was having some headaches as well at that time. And at 6 months, his pain had resolved, his imaging had improved. His right vertebral artery dissection that had the double lumen had actually completely healed, and there was partial recanalization of the left vertebral artery. He did have some pain twice a month, but it was NSAID responsive, and he was very okay with that at that point. So we made the change over to aspirin 81 milligrams daily, and at 12-month follow-up, he was doing really well. So in summary, cervical artery dissection accounts for up to 25% of strokes in patients less than age 45 or equal to age 45. These patients have a paucity of typical vascular risk factors. Underlying arterial abnormalities likely predisposed to environmental triggers. Presentation in which you should really consider cervical artery dissection are those with unilateral head or neck pain that may radiate to the face with or without neurologic symptoms. But a high index of suspicion is often needed to make the diagnosis. FMD is strongly associated with cervical artery dissection, and these patients may be a spectrum of the disease process. So they both cervical artery dissection and FMD overexpress the same factor 1 polymorphism, suggesting there might be this genetic link. And treatment is really focused on preventing ischemic complications, and in general, less is more unless complications arise. So you consider anticoagulation or, in some cases, antiplatelet therapy for 3 to 6 months, and then re-imaging thereafter. Overall prognosis is very good for most, and the best indicator for long-term outcomes is the NIH stroke score at patient presentation. Some remaining questions. I think the debate for antiplatelet versus anticoagulation continues. We need more data regarding the direct oral anticoagulants, although in our experience we've had good success. And then I think there's a question about whether or not we should be screening for FMD in all cervical artery dissection patients given this corollary, and if so, if we're going to screen, what's the best approach? Should it be ultrasound, or should we be getting a CT angiogram on all these patients, which is better at identifying FMD? I'm not sure I know the answer to that. And I think that's it. Thank you. Yeah. Any questions?
Thanks very much. That was really, really good.
Thank you.
The photo of the guy from Portugal, Monas.
Yeah.
It was very kind of you to present that, but I don't know if you know this, but I think his award is considered the biggest mistake in the history of the Nobel Prize. Prefrontal lobotomy for mental illness has not exactly panned out.
Absolutely.
The other thing, question more serious, I guess, is have you studied, or has anyone studied identical twins with this syndrome? And if so, what did we learn from the identical twins?
So they've done familial studies on both cervical artery dissection and also FMD, but they were very small numbers. I'm not aware of any studies that included identical twins with this, but there are some family cells that seem to cluster with both cervical artery dissection and also with fibromuscular dysplasia.
In this case, it was bilateral, and I'm wondering, is there any protocol for dynamic imaging with rotation of the neck to see whether you can actually document what's likely to have happened to cause this?
No, they typically don't do that. Really, with just regular cross-sectional imaging, you're able to make the diagnosis. I think in a majority of cases, we don't come up with one clear inciting event, particularly for the spontaneous cases that don't have a reported trauma. So no, it's not done.
Thank you very much.
Thank you.